Thank you, Fatima, and good morning, just everybody. So today I would like to talk to you about oral delivery of non-absorbed biomolecules to the GI tract. And in particular, looking at some of the challenges. There's been a huge explosion with the microbiome, with the exploitation of the gut-brain barrier, and a whole sort of swathe of new molecules that people are using for therapeutic areas. And with that has brought a whole range of new challenges. As pharmaceutics developers, we always know that the development of, one of the challenges that we've always had is absorption. Poor absorption was always the go-to problem, wasn't it? Well, what happens if you don't want absorption, you're not looking to see absorption? What are the challenges that we have here? And over the next sort of 20 minutes or so, I hope to take you through some of them and some case studies that we've seen within BDD. But first, I just want to take a little moment to introduce BDD. We are, in essence, a drug delivery company based in Scotland in the UK. There are sort of three key arms to what we do. We focus predominantly on modified release formulations, developing products for our clients and for our partners. But we also have our patented drug delivery technology, Oralogic, which is an oral technology that allows timed release of drug at specific times post-dose. And I'll talk a little bit about that later as we go through the presentation. We also have a co-located clinical arm where we can do clinical evaluation of drug formulation technologies, and in particular modified release technologies. And that's using radio labeling of the products and a technique known as gamma scintigraphy, which some of you will have heard about before, but if not, we will take you on a little journey through that again today. And the third arm of where we work is within what we call BDD Swift. So that's where we take the formulation development, GMP manufacturing, and the clinical assessment of products, and we put those together to allow rapid assessment and rapid development of your product using clinical data. So I apologise. For this first slide, I'm going to duck between small molecules, larger molecules, cells, basically anything that's non-absorbed, because there are a large range of non-absorbed products. And what I'll talk to you about today actually is relative to all of these different types of products, although as I say, we're looking more at biomolecules when we look at the clinical examples later on to see how we can help in the development of those products. So there are a whole range of non-absorbed products, so locally acting products. So we've got some small molecules here, vancomycin, which is delivered orally for the treatment of C. difficile. Mesalamine, similarly, for ulcerative colitis. Although there is some absorption with mesalazine, it is actually locally acting, and the product needs to get to the site of action. There's been a huge amount of work over the last many years on repopulation of the microbiome. Possibly the most obvious one for us all is the one we see in the supermarket every day with your probiotics, your friendly bacteria that we're encouraged to take in to repopulate our GI tract, but also use of fecal microbiota transplantation, which is a really necessary treatment for some people with, for example, C. difficile. If you have to basically repopulate your gut microflora using somebody else's healthy gut microflora. So there's a lot of work in this area, as you can imagine, to make that a little more user-friendly moving forward. Bacterial therapeutics has just exploded, and that's where we're using naturally cutting bacteria. Some of those may be engineered to have new properties and better properties to trigger this gut-brain axis, where there's a two-way conversation between the GI tract and your brain, and have shown that this can actually help, orally to treat disorders such as autism and other CNS disorders. There's also a lung brain barrier, which is quite interesting, again, using the microbiome of the lung to treat different disorders. And so, as I say, that piece has really exploded. We can also add sort of sequestering or detox agents, so agents that you put into the GI tract to neutralise, for example, gliadin for, or glutenases to take away gluten for people with celiac disease. And of course, the challenges with that is again about the site of action, where you're wanting to keep your product, deliver it to and keep it within the stomach where your gluten is. So these are just some of the non-absorbed products. There are some which are not absorbed and act locally, but we're trying to get absorbed, but that's not the focus of the discussion today. So small molecule versus biomolecule, and this is a big generalisation, so please don't shoot me for this. But there are huge differences between the products. Namely in preparation, so small molecules tend to be chemically synthesised, the use of crystallisation, whereas biomolecules, you've got fermentation and drying and aqueous phases. Potency can be quite different as well. Generally, small molecules can be 100%, but you see a lot less potency from biomolecules, and I guess as we continue to develop those, we'll understand and get better results. Getting better potency for biomolecules uses techniques such as, lyophilization, spray drying, and we'll talk about that and the challenges of that in a minute. I've said here that there is no oral absorption of biomolecules. That's not entirely true. For some biomolecules there are, but on the whole, they're not absorbed and they act locally. And within that, you do not have systemic action, but you have action in the local site where you want to see that change. So targeting specific areas of the GI tract, targeting specific receptors within the GI tract. Often the biomolecules are not stable in the stomach, so we have to protect them from the mechanical forces and from the acidic environment of the stomach. And so with that, they need to be targeted to specific areas to try and bypass all those challenges. And perhaps the most important one is validation of clinical or successful delivery. With typically what we would do with a small molecule is you would deliver it to the individual, you would take bloods as we go along, you would have a lovely pharmacokinetic profile, and you would be able to address, have we hit the pharmacokinetic peak that we need? But where you have a locally acting product, say for example in the colon, you just can't see that. There isn't that quick, rapid readout, and that's what I want to address today. So just to recap on that, the unique challenges that we have with biomolecules is that they require complex processing for oral delivery to keep them stable and also to enable them to be delivered orally. Many of them, as I say, are really degraded by the acidic environment in the stomach or by peptidases in the GI tract, and so there's a number of different formulation strategies that we have to adopt to try and really be successful in delivering these molecules. And again, a lot of that's to do with targeting the site of action and specific receptors within the GI tract. But ultimately what we've got here is there's no fast readout of performance. And so everybody that we've spoken to recently who's working in this area keeps saying to us, and it's the same phrase, we're working in a black box. How do we move forward quickly? How do we know that what we're doing is the right thing and that we're getting the performance and we're doing the right development work to get where we need to be? So right back at the beginning, processing of biomolecules. Typically they're derived from liquid processes, unsuitable for direct delivery to man. So we have problems with refrigeration, stability, transportation. Commonly these molecules will be injected. So Soren talked about challenges down that route as well. Here we're looking at the challenges of trying to put these molecules, to deliver these orally, which would get over the problems with the injectables, but it feels like we have the expression out of the frying pan and into the fire. Similar challenges there. So stabilization of protein structures has been well characterized over the years. There's a number of excipients that we can use, sugars, trehalose, for example, to maximize the functionality of the biomolecule as you develop into a drug substance. Drying, typically freeze drying or lyophilization, spray drying are commonly used methods, but they result in problems which will become very apparent in a minute when I show you some clinical data, where you have very fluffy products, very poor flow, and low density, which is pretty critical. And the other thing to bear in mind is that biomolecules tend to like processing at low temperatures, so some of the techniques which are available to us to help with oral delivery are really not much use with a biomolecule. So what techniques can we adopt for successful oral delivery? Well, protection from the harsh environment of the stomach. Relatively easy, you would think. There are enteric coats that we can apply to tablets, to capsules. There are proprietary capsules that are available at the moment which delay the release of a product and protect the product from the stomach environment. If you're working with peptides, you can add peptidase inhibitors to protect the product from enzymatic degradation. Challenges with that as well. How much peptidase inhibitor do you need to have, particularly if you're delivering to small intestine where there's a large volume of fluid still. You're assuming that we've come out of the stomach, avoiding the stomach at all costs. But even in the small intestine, you have a large amount of fluid in a relatively rapid transit time, which will sort of decouple, if you like, or mean that the peptidases and your biological molecule are sort of decoupled and not co-located. We can use technologies to deliver the biomolecules to specific areas of the GI tract. So if you want to hit the colon, say for example you want to make sure that your peptidases are co-located with your biomolecule, your peptide, then you can target the colon where there's less movement and smaller pockets of water. So try and avoid the situation where you're diluting out your functional excipients. And also you need to be careful that the process of making a capsule or a tablet, you're not compromising your drug with those manufacturing processes with, for example, heating or compression. So this black box that I was talking about before, in the absence of absorption, PK is not possible. So typically people will go to, when there's typical people will try and have different models, different in vitro models to simulate the GI tract. And I've picked one here, just a paper that I pulled out randomly looking at trying to model like a dissolution method for modelling release of mesalazine in different subjects. Very, very complicated dissolution process, trying to mimic the transport through the GI tract, changing pHs, etc. But in the absence of being able to do clinical endpoint studies, which will take a long, long time and still may not be sensitive enough or rapid enough to tell you how your formulation is developing, are these in vitro predictive models actually telling us what's going on in the human gut? And my answer to that is absolutely not. And Andy Lewis talked about that this morning, just the complexities of the GI tract and how in vitro modelling, while it can give us some answers and maybe a steer in the right direction, really isn't the ideal way to look at how our formulation is developing and to develop that product. You really want to, looking at all the challenges that you have within the GI tract, it's just physically impossible to replicate that in a beaker. If you look at the graph on the slide here, on the left of the slide, we're looking at different pH as measured by a capsule. Different pH, you go from the stomach where you pH 1, 1.2, straight up to pH 4.5 when you come out of the stomach, and then just continued changes as you see over time as the capsule goes through the GI tract. I spoke about fluid earlier, and this is a nice paper which looks at the amount of fluid in different individuals, and so this is following dosing of a drink. So you tell your patients, take a tablet, 240 mils of water is the standard, and what happens? We can see very, very quickly that 240 mils of water goes. You can see this within 20 minutes you don't have 240 mils of water anymore. So imagine that as compared to your dissolution beaker, vessel where you have 900 mils of media for the whole 12 hours. So, they're really massive differences. And you can see here inter-individual differences are huge as well, and we see that quite a lot in our clinical facility. But you've got This is just showing the amount of fluid as measured by MRI in a number of different individuals. And it ranges from 0.7 to 160 ml from individual to individual. So we have all those different challenges from the human body that we really need to understand if we're developing our products. We've got in the stomach the pressure, the sort of machinations, these movements. You've got the presence or absence of food, and just the general agitation. Take that to the other end, from the stomach to the colon, where there's really very, very little movement, tiny sort of isolated pockets of liquid, and absolutely no agitation at all. So how we can recreate that in vitro is really, really very difficult. And we are huge advocates of when you can get into man as quickly as possible, particularly when you can't see what the readout is in blood. And that's before we get to the even more exciting, complicated parts of the GI tract, so your microflora, which we're talking about. It can differ from disease state to disease state, from individual to individual. We have a raft of different enzymes that will act on your product and your tablet, your capsule, and also the presence of bile salts. So there's been a lot of work done on in vitro analysis and in vitro testing and models, but they really don't. They're not a good substitute just for going straight into man. One way that we can get a rapid readout for formulation for molecules which are not absorbed is using imaging. And in vivo imaging allows you to actually physically watch what's happening to your product as you dose it into an individual or across a range of individuals, so that you can assess, is it going to the right place? Is it doing what we think it's doing? Or is it just passing straight through and nothing's happening? But that gives you a rapid readout, actually a real-time readout. So if you radiolabel a formulation and dose it to man, you can stand an individual in front of a camera and you can see what's happening to your tablet there and then. So it's even faster than doing pharmacokinetic studies. If we couple that with our formulation development and introduce an adaptive clinical study at that point, you can take that real-time imaging readout, look at what's happening, and adjust your formulation in real time and assess a different formulation. So, for example, we will go in the first study with your target formulation. Typically, you would decide, a typical development piece, you would decide on a target formulation, you would test that, see if it works, and if it doesn't, go back to the beginning. So we would start with the target formulation, say, for example, a percentage coating, radiolabel that, put it into man and see, is it hitting the section of the GI tract that we want it to hit? If it's not, increase the coating or decrease the coating accordingly. And that can be for any functional excipient that you have. You can make those changes using that real-time imaging data and not having to wait for pharmacokinetics. So radiolabeling imaging, the technique is known as gamma scintigraphic imaging. And basically what that is taking a small amount of radiolabel, adding that to your formulation, dosing it to your volunteers, and then imaging sequentially to see what happens and what is the fate of your formulation in man. We radiolabel an excipient within the formulation. We don't radiolabel the API. We don't want to change how that's performing in any way. So we would radiolabel one of the excipients in the formulation and check that what we're doing with the radiolabel doesn't affect the performance of the tablet in vitro, so that we know it's reflecting, or hopefully reflecting, what happens in vivo. We can use two different radiolabels, technetium-99, which has a very short half-life of 6 hours, or indium-111, which has a slightly longer half-day of 2.8 days, half-life of 2.8 days. The dose that we use is very, very low, typically less than you would get if you went on a long-haul flight to the US. So it's a very, very safe method of analysing your formulation development. And of course, you can use either one or both of these radiolabels. So if you want to look at two different release profiles, you have a more complex formulation, then you can combine both indium and technetium. And so here we've just got some of the images that we've taken, just sample images that we've taken over the years at BDD, to show you what sort of things you might see. So the first image is just an intact tablet in the stomach. So you can see very tight ball of radiolabel, and the tablet is just staying in the stomach. Once it starts to disintegrate, you can see the radiolabel separating and moving away, and so you can sort of call time of onset. And the data can be quantitative, so you can have from start of onset to end of onset. You can measure kinetics of gastric emptying, all sorts of different things. The third image there you can see is disintegration in the small intestine, and the last is disintegration in the colon. And really, that's everybody's favourite at BDD. We always say you can't beat a good colon. The images are lovely, proper heart-shaped images, and you know when your product has reached its target. So why would we use gamma scintigraphy? Well, for biomolecules, we would use it to show that you've got targeted release to the site that you want to release to. Product performance, if you want it to be sustained over a period of time, we can show that also. We talked about the enzymes and sequestration for treatment of celiac disease and sort of getting rid of gluten in the stomach. If you did that with a gastroretentive product, then you want to show that gastroretentive product is actually retained within the stomach and doing what it needs to be doing. And again, for formulation improvements, so that adaptive clinical study where we can say, well, actually, our first attempt at this was pretty good, but actually it could be better if we tweaked this enzyme or the other enzyme. This excipient or another excipient. So I talked earlier about being able to model what happens in vitro, what happens in vivo. And this is a nice example of using gamma scintigraphy to show where you're going to get differences that you will never see in a dissolution bath. And this is gastric emptying of multiparticulates. It was a capsule. We radio-labeled the mini pellets within the capsule, and then we imaged what happened with those mini pellets. And what we saw was that gastric emptying of the mini pellets can either be as a bolus, so they either all release as one, or gastric empty as one, or as you can see here in the images, so this first image here, this first image here is the capsule with all the mini tablets together. The capsule's disintegrated, you can see the mini tablets now coming out in the stomach. And here, after 75 minutes, you see some of the mini tablets are being gastric emptied, but some aren't. So when you're getting, in this case it's absorption, in the small intestine, you're getting absorption from half of your product. So you will never replicate that in a dissolution bath, but you can see it happening in using gamma scintigraphy in man. And that can start to explain some of the images that you see, or some of the results that you're seeing with the product. This series of images here is really very, very interesting, and it touches on what I said earlier about the density of biomolecules. This is a capsule with a biomolecule in it. It's been produced by spray drying, and you can see here the typical capsule within the stomach, but interesting, it's floating. So it's staying up quite very, very high in the stomach, starting to come down a little bit here. But 25, 40 minutes post-dose, you would have expected in a fasted individual, you would have expected gastric emptying. It hasn't gastric emptying because it's very, very low density and it's floating on the content of the stomachs. So typically using in vitro methods, you would have thought that's gastric emptying and it's going to hit where you want it to hit. What we actually see in this is regurgitation. So the acid is coming back up. The capsule is actually coming back up into the esophagus and coming back down again. And it takes, post 100 minutes before that starts to do what it is supposed to do and get into the small intestine. So, yeah, a challenge to think about. You would never see this in a dissolution bath, but yeah, the low density, you need to look at some densification methods to try and keep the capsule doing what you think it should do. Here is an interesting one, so very similar images to before. We're on the left, so this is imaging that we did on a delayed release capsule, a proprietary delayed release capsule, which is to protect your product from the stomach. And on the left, you can see an intact capsule, and then on the right, just after 15 minutes, this delayed release capsule has released in the stomach. So they're maybe not doing what they say they're supposed to do. And if you look at the literature that's been published by the company here, 20% of their capsules go within the stomach. So if you're using that to protect your biomolecule, you know, it's maybe not giving you the answer that you want. And what are the clinical implications of this? Well, this is, if somebody is here from Finch, I apologise. We're not working with Finch. We just thought this was a really fascinating paper, poster that they developed. So they were doing a clinical trial looking at engraftment. So that's how delivered bacteria populate the microbiome. And it's a lovely paper, some really nice work gone into that. But engraftment of their product shows a bimodal distribution. Now, Finch themselves in this paper say that they think that's due to imperfect clearance on vancomycin from individual to individual. But if you look at this with the proprietary capsules, is that actually the case? Or is maybe what's happening, some of their product is actually releasing in the stomach and is being degraded by stomach enzymes and the high acidic environment before it's getting to the area that you'd want to, the area of action in the small intestine. And of course, if you did gamma scintigraphy with that, you're no longer working in that black box. You're no longer waiting for the expensive long clinical efficacy. You can actually see, oh, okay, so in these individuals where we didn't get full engraftment, they released in the stomach. We don't know. I'd love to do the study for them, but it's a good explanation. So we talked about targeted drug delivery. There are, of course, enteric-coated processes and also pH-dependent coatings. We have developed a timed drug delivery process, which I spoke about before, which allows you to use the gastric transit time to deliver to different areas of the GI tract. It's a tablet within tablet formulation, so you've got a protection within the stomach, and it's made of waxes and cellulose excipients, so you get compression, cushioning during compression to protect your product. So using different times, we can hit all of these different regions within the GI tract, so we can either target any of these different regions that you wish to achieve. And I'm not moving forward now. And this just shows the use of orologic to target the colon. So enteric coat protects you in the stomach. Then once it comes out the stomach, you start the erosion of the barrier layer until the time that the tablet reaches the colon and you have disintegration in the colon. And here we have some lovely gamma scintigraphic images demonstrating that. And you can see here this classic harp shape that you have of the colon when you have delivery in the colon. And of course, we can do very, very quick proof of concept to show that works. This is some work we did with a client using orologic to deliver peptides. So they're actually looking for absorption in this case. But we did a dual pulse product where we had an immediate, as soon as the product comes out the stomach, small intestinal release, and then release in the colon, and just pure release in the colon with our orologic technology. And you can see that we get a 5-fold increase in absorption of the peptide using targeting to the colon, where you've got co-location of all uric function excipients in a small pool of fluid. And we're doing our own study at the moment to show this in man and hopefully get some nice data from that. So hopefully I've given you all some food for thought as to how you can use imaging to help develop your formulations, to take you away from that black box where you just don't know what's going on. The good thing about this is because you're getting an instant readout on your clinic, and we can manufacture the day before we do the clinical study. You can get the results from your formula, from this development and clinical assessment within 6 to 7 months. So it's very, very rapid as compared to having to do a clinical endpoint study. Thank you.